depression standard of care, yeah, if I can talk, the depression standard of care. And of course, it's not going to cooperate. So, why are we doing a depression standard of care? As a lot of people are asking. A lot of our patients do have depression as a part of their problem list. It's not an uncommon diagnosis. We feel like we can be doing more for them as an agency. Hopefully it will, by doing this, we will assist with a faster recovery and prevent that idea of the rehospitalizations. There is an outcome that is reported on Home Care Compare for depression management, so that is another piece of it, of course. Feeling like we needed a better way to address patients that have depression and then to give a tool to you as staff to work with, to use.
So this is an agency thing, not a mandate coming down from.
Correct, correct, it is. The mandate coming down was the whole screening for depression as part of the OASIS. We're just taking it a step further, which is part of the whole depression outcome and wanting to make sure that we're doing all the pieces that we can for all of our patients. So thinking about the fact that a lot of people that have chronic pain or chronic disease have depression or elements of depression, and that can create a real vicious circle or cycle. And knowing that there's ways that we can try to help interrupt that cycle and help to get in there so that we can hopefully make a difference for people, and then they can respond better to their treatment and to what we're trying to accomplish with them. And I do apologize because for whatever reason, it's a viewer rather than the actual PowerPoint program, and so it tends to get stuck. Recognizing that depression is a medical condition, it often goes undiagnosed and untreated, in part because people don't seek help for it, but often maybe because people don't realize that what they're fighting against is something more than just feeling down. So depression is a medical condition, and it is more than just feeling down. That is one of the symptoms. So we've developed a standard of care to address that. What that involves is basically completing a more in-depth depression assessment when that is appropriate, and having a problem-based care plan for depression. Not huge, but we'll be looking at how that will impact us. This is for all professional staff, not just nursing, although as in a lot of the other disease-based issues, nursing is going to be the primary discipline dealing with that. But we do expect all the therapists to take part in it as well. And maybe I will just leave this open and we will go this way. In your packet, and I do have packets for those of you who came in late, there is the standard of care on paper. It is basically just the two goals that patients can identify the signs and symptoms of depression, and that will, by the time we discharge, would be independent in self-management of that depression. And then we have as our interventions the depression screening protocol and the depression care management protocol, which is also in your packet. The depression care management protocol is the piece of paper in your packet that has the 3 large arrows pointing down. And so this whole thing is built on that protocol. The part we're going to start with and spend probably the most time on is the whole assessment piece. Assessing the depression severity using the PHQ-2 and the PHQ-9 if indicated. The other piece that's going to look a little different is, you know, when you admit a patient, that admission through discharge plan problem on the care plan has several different interventions that are on everybody's care plan, so everybody's supposed to be doing those things. This one, the depression one, conduct the PHQ-2 assessment on admission visit piece is going to be now a part of the admission through discharge problem, so that every single patient will have it on their care plan. The idea of doing the PHQ-2 is nothing new. We've been doing that on all patients because of the OASIS upgrade about 4 years ago. So the PHQ-2 piece is nothing new. It's just now going to be part of the care plan. The part that's new is the second part of the statement that says if the score of the PHQ-2 is 0 to 2 or negative, we would repeat the PHQ-2 in 2 weeks, and there's a blank spot there to put the date in. If the repeat PHQ-2 then stays 0 to 2, we're done. That's it for the depression protocol. If, however, the score of the PHQ-2 is higher, 3 or higher, either on the first risk assessment or the second one, we would then move on to do the PHQ-9, and that is when the problem-based care plan will be proposed and need to be accepted. So that's the part really that's different. The PHQ stands for Patient Health Questionnaire. It is a standardized, validated depression risk assessment tool. Inquires about the frequency of the depressed mood and that inability to experience pleasure, normal activities that bring pleasure or are enjoyable, and it looks at a 2-week time frame. The PHQ-2 is the first 2 items in the PHQ-9, so you've already somewhat familiar with the PHQ-9 in that sense. And the purpose isn't to diagnose or to determine how severely somebody is depressed, but to screen. It's that first step approach. So those who, again, screen positive should be further evaluated with the PHQ-9. So the research that was done by the committee indicated that, yes, we were doing the PHQ-2, but that's really not quite taking it far enough, so hence the protocol. This is what the PHQ-2 questionnaire looks like. This is what you're used to seeing. You see it every time you do an admission. The top part is what's in the OASIS, and that's what it looks like in the OASIS, and the bottom part is our risk assessment, and that's what you see in the risk assessment page. That's not going to change. That's going to stay exactly the same. The PHQ-9 is going to look like the 2, only it's going to have the 9 questions instead of just the 2. And it will live in the risk assessment area of the note. The problem-based care plan that will be proposed if the PHQ-2 score is higher than a 3, or if they have a current diagnosis of depression. Same way as it's proposed now. So when we do that, of course, we have to fill in the 2-week time frame, like I mentioned before. Unfortunately, that is going to be your only reminder or only cue that you have to do it, because we cannot turn it pink again. So the risk assessment itself isn't going to alert you that you have to do it. You have to be looking at the care plan and following the dates that are in there. So that piece is the one kind of negative about it. The care plan, and in your packet, you should have a page that looks like this, is what is currently in the care plan. It may be tweaked just a little bit till it gets released next week from some feedback we've been getting. But the first 3 goals, or the first part is the goals. The first goal says the patient will be able to identify or set their own goals for self-care and pleasurable activities. And the patient goal is, and then there's a blank for you to fill in what the patient's goal is. This is not going to be driven by what we want them to do, it is what they want to try to accomplish. So this has to be asking the patient, what is it that you would like to be able to do that is going to help you to feel better? If it's just getting up and getting dressed every day, that's an appropriate goal. If they then meet that goal, you can add another one in and have it updated as often as is appropriate for however long the patient's on service. If you add a goal or update it, you don't have to generate a verbal order, because this is patient-driven, not physician-driven. Physician's not really going to care about this piece. This is for the patient. So we have something we can help them measure. Then the second one is, by the time of discharge, patient will be able to identify the need for continued monitoring and management of their depression. And then, of course, we have our depression management throughout the episode. And we will look at the rest of the orders in just a little bit. This is what the PHQ-9 looks like. You do have one in your packet. We will have them available for everybody when this gets rolled out. The recommendation is, if you have a patient who needs to have a PHQ-9 or risk assessment done, is that you actually hand them the paper and ask them to fill it out while you're doing something else. The thinking is that patients will probably be more honest if they're doing it themselves rather than talking to you or answering questions that you're verbally asking them. Of course, that is the assumption, and that they can read and do that. But to actually try to get a accurate response from people, feeling like it's probably going to be more likely that they would respond honestly if they're writing it down themselves. And then you would just go through your risk assessment and put in their answers, and it would only take you a matter of a couple of seconds to do that. So we've done our assessment piece. The next part of the protocol is coordinating care, if needed, to contact the physician if there's issues with their medications or something's going on. Consider referrals to another discipline if appropriate. So you think about people that have chronic pain or having mobility issues, maybe it would be appropriate to get social work therapy out there to help them. Getting social work out there to help them for community resources if appropriate as well. Social work team is on board with this. We're a little bit limited right now because our numbers of social workers have diminished, but they're on board and they want to be a part of the process as well. Managing antidepressants. Obviously, we do not diagnose or manage in that sense, but helping patients, or talking about it with their patients, but helping them understand what the medication's for, the education piece. Helping them understand that when they start an antidepressant, they may have some symptoms, but those usually resolve as they've been on the medication for a little while. Talking about side effects, and so asking, if they're having side effects, maybe talking with them about talking to the doctor and getting that medication changed, because not every antidepressant is going to affect every person the same way. So if it's not being effective, or if they are having side effects and they need something different to facilitate that conversation with the physician, that's the kind of management we're talking about here. And in your packet, there are two different forms. One is common side effects of antidepressant categories, and another one is the way physicians should be titrating up the doses of antidepressants so that they become more effective for patients. Those tools are for you. Those are just educational pieces for you as staff to kind of be aware of the different categories of meds that can be used and what that looks like. And then the other piece then is instructing patients and family with the patient education sheets. And currently in your packet is a sheet that has the Affiliate logo at the top that is titled Depression, and that is patient information. We are in the process of revamping that, so hopefully by next week when this is all launched, those will be ready, and that would be more in the stoplight format for patients to help them kind of look at it and see it. This form is not real patient friendly, and if you're depressed, you're probably not going to want to sit and read through that, like probably most of our staff are feeling right now at this moment. But anyway, the stoplight piece will be available and would have much of that same information. The information that's on that sheet is really good stuff, and it would be ways you could talk about some things with your patients. There is a small blurb in the admission packet that talks about depression. This is in addition to that. This is not repetitive of that, so there is information there for patients. And we can keep this as a tool as well if people feel like it's helpful. And then the assisting patients in goal setting for self-care and pleasurable activities. And that is the other big piece of what we're going to be doing, is helping patients come up with short-term goals that they can try to accomplish. Not something big and lofty, but a small, steps, those baby steps to help them make progress in what they're trying to do. So basically that's what I just said with the other slide. It's looking at whether or not we do need to refer other disciplines, utilizing the education sheets, discussing meds, and helping them set their own goals. If we keep patients on service who do have depression and they're on longer than a week or two, we're getting into those follow-up visits and continuing to monitor, coordinate care as needed, manage their meds, and continue instructing and assisting them with reviewing that piece. So it's an ongoing process. It's not just a once and done deal like PhD2 was before. So that's kind of where it's going, is just helping them to maintain that and manage that. Oh, I did want to just say, if at any point in this process it becomes, you recognize that their PHQ-9 score stays the same or gets worse, is above a 9, or that they are showing signs of suicidal ideation, that is when you want to call the doctor. If it's severe enough, crisis intervention or 911. You're not going to be leaving people home alone who are expressing suicidal ideation. So we're going to make sure that we aren't leaving people in that position. And this is all stuff that we're probably all doing anyway. It's not some brand new idea. I mean, I think when we take care of our patients and we're dealing with them and talking to them and building a relationship with them, we're doing these things. The problem-based care plan now gives you a way to document all that without writing a whole narrative about everything that's going on, because your problem-based care plan now has where you can check off, these are the interventions, you can check off that you've talked to them about setting goals for themselves, you've talked to them about their meds and side effects of their antidepressants, that you've talked to them about the importance of continuing to do all of those things to help them stay in that, move towards being more healthy and more controlled that way. So, in a lot of ways, I think we probably do a lot of these things, and we now have a better tool for documenting it, which should help. And again, if your patient isn't depressed, after you've done that second PHQ-2, you're done. You don't have to worry about any of this stuff. So I don't know that it's going to be on a tremendous number of care plans, but there are those that it will need to be there. With the interventions, the PHQ-9, you are going to repeat it. If the score is less than 10, you're going to repeat it twice. 2 weeks in a row, and again, putting dates in there. If it's a 10 or higher, or if the suicidal ideation is there, referring to crisis intervention, the physician or EMS is appropriate. And then the other ones are just what we already talked about. We have the initial instruction and then the assess and recall, and resolving those as they're completed. If they don't apply, if there's something on there that doesn't work for your patient, you can delete that out. And if patients aren't willing to do this, obviously they have to be involved and somewhat motivated to be a part of this. If they're not willing to do this, you can't force them, and so then you wouldn't put that on your care plan. You would just address in your documentation that you approached it with them, talked about it with them, and they were not interested in participating. So it's not something that you have to force on people. I also included this, it's not specific to the depression standard. It's kind of an across-the-board thing. And most of you in here are nurses, and so I don't think it's probably something that you think about much. But I know that some of the other disciplines go in, and when they're going in to do their care plan charting, they can limit the discipline to their own discipline. And then they only see their own interventions, which is fine, that's great to do. But I'm just reminding everybody, don't forget about the unspecified interventions that are at the bottom of that list, because all of the all the things that are non-specific get captured in the unspecified part of the care plan. And if you ignore that piece, you're missing a lot of things that need to happen. So like all the depression stuff is in the unspecified part of the care plan. So if you don't look at the entire care plan, or if you just look at your discipline, you're not gonna see any of the unspecified things. So like the diabetic foot care, the fall prevention, pressure ulcer prevention, pain, and now depression are non-specific, and so you need to make sure you're seeing those things. Which also brought up another point in one of the discussions, that nursing, if you pull out before the other disciplines, you want to limit it to SN and only resolve the goals that are related to nursing specifically. You don't want to resolve the unspecified goals. So just make sure that when you're pulling out before the other disciplines, that you're only resolving nursing goals. So this was just a little reminder for that. So that's the depression standard. Anybody have any questions about that? Yes, ma'am.
I just have some questions on the antidepressant fact sheet.
Mm-hmm.
Can you tell me the names? Like, I know that Prozac is an SSRI, but like, what else falls under that category so we know, which are which?
Okay, we can come up with a list for you.
Okay,
Yeah,
okay.
that's a good idea.
Sometimes I think some of the people need some counseling, and would social work be able to take care of that, or does that have to be a doctor?
You can talk to social work about that and see if they can come up with some counselor lists.
So we could refer them?
Yes, absolutely, and that would be a great time to get social work involved, just to help patients realize what resources they have available to them. So you shouldn't have to be digging for that information. You would get an order to refer to social work and let them handle that piece. Yeah, good point.
What do we do with the long-term patient that has a diagnosis of depression that we're only seeing monthly performance changes?
So we can't do the weekly screening, right? That's a good question, and I'm not quite sure what the answer should be for that. I'm not gonna give you an answer yet, but I will find out from the managers what they want us to do for those. Because if the only thing we are seeing them for is Foley care and it's once a month, that's a whole different animal we have to deal with.
There is a soup visit in between, but it's not a visit, it's just, hi, how you doing?
Right, right. So let me do a little bit of looking and I will get back to you, because when we do turn everything on, I'm gonna send out an email with some of the questions that have come up, and that's a great question. Anything else? Nope. All right, well, that's it for the depression piece of things.